So I'm Peter McCullough. I'm an internist and cardiologist from Baylor down in Texas at Baylor University Medical Center. And my principal research interest is really the interface between heart and kidney disease. So I'm going to go over a common problem of contrast nephropathy or kidney injury due to the dye that we use in various forms of X-ray imaging and in heart catheterization. And we just had a patient of mine at Baylor who has heart failure, and she has 17 years of diabetes and has been on insulin for 8 of those years, who has a baseline creatinine. I had her for 3 years now. Her baseline creatinine was about 1.8. I do have to say over the last year it's about 2 or 2.8. And she does have proteinuria, has about 300 milligrams per gram of albumin in the urine. And so she came in with a heart failure exacerbation. And at Baylor, frustratingly, our ER doctors feel compelled in every patient to rule out pulmonary embolism. And in my view, she didn't have a whiff of evidence for pulmonary embolism. It was a heart failure exacerbation, but they put her through a contrast CT in the emergency room. And they gave her 80 cc's of contrast as part of the contrast CT protocol. Well, she came in the hospital. We started giving her some Lasix. Her creatinine went from about 2 all the way up to 6.2. And we stayed in the hospital. We had to withdraw therapy, and she got really sick, and what have you. And the point is, this contrast administration can be a real problem for our patients. I have another gal who's about my age, and she has no diabetes or other medical problem except for an unusual vascular dissection syndrome, where she has had fibromuscular dysplasia of her arteries, and about 10 years ago she had a dissection of the descending aorta, and subsequently 2 years ago she had simultaneous dissections of the LAD and right coronary artery. So she has, it's not Ehlers-Danlos syndrome, but it's probably some variation of this. She looks very active, exercises, young gal. She has had so many contrast studies and contrast CT studies that her creatinine now is about 1.3 or so, and her estimated GFR is about 49, and she's in her 50s, and I think she's taken the cumulative impact of contrast-induced acute kidney injury over and over again. I think the number of CT scans she's had with contrast is over 30 now, because I sent her for a consultation at Mayo Clinic, of which they, of course, repeat everything that we've ever done, and it keeps going and going. She's had at least 4 or 5 heart caths. So the bottom line is contrast-induced acute kidney injury is real. And what I want to do is just go over the data, kind of get you warmed up to the problem and sensitized to it, and then show you what we know with respect to some evidence-based prevention approaches. So let's go ahead and dive into this. This etiology of acute kidney injury is worth talking about. When we do a heart cath procedure, the acute MI itself can be a source of acute kidney injury. So it's been shown, forget the catheter, just the acute myocardial infarction sets off some signaling to the kidney. So we've shown in some earlier research that the heart releases, actually releases some free iron, because myoglobin is quite rich with iron. So the free iron hits the kidneys, that's part of the injury. And also there's quite an activation of neurohormonal systems in the setting of acute MI. So part of the injury is actually not the contrast itself, it's actually the acute MI. Giving iodinated contrast in the cath lab, no doubt about it, is directly toxic to the kidneys. And then our catheters brushing up and down the aorta and our wires do cause some atheral microembolism. And years ago, when I was in Detroit, we did a study of over 1,000 patients. We collected the blood coming out of the guiding catheters. Now, we were using large guiding catheters at that time, 8 French catheters. But in 50% of cases, we had measurable cholesterol crystals in the back bleeding of catheters. So I can tell you that's just what's coming down the lumen. I can tell you what's going around the outside. So atheral microembolism does occur. It's not the blue toe syndrome that you've been told. I think it's actually, the body's fairly forgiving to this, but this atheroembolism is part of this quote acute kidney injury we see after the cath lab. Now we have other features involved. So a lot of our catheterizations now, at least half of them, are urgent. So we have inadequate time for prophylaxis, hemodynamic instability. We tend to use higher contrast volumes. So nowadays when we go to the cath lab, we not only want to do a diagnostic cath, but we want to offer some form of therapy with respect to PCI. So we have a lot of test injections, and we use much more contrast than just the diagnostic cath. Now, there are biologic factors I've mentioned, increased neurohormones. There actually is decreased renal blood flow during the setting of acute myocardial infarction, the release of labile iron, embolism, and all these relate to prolonged stasis of contrast in the kidneys. If any of you have had contrast, I know I have for a CT scan one time. When you have contrast, after the nurses finish with you, you really have to pee. I mean, you want to, you actually, it has a diuretic effect. Normally contrast, you kick it out into your urine fast because it's water soluble. Okay? What's of interest in the setting of contrast-induced kidney injury, you actually don't get rid of it. It actually tends to dwell in the kidneys and causes a persistent nephropathy. Okay? So it's a constellation of the dye causing the kidneys being set up for injury, the dye causing some a chemical injury, as well as decreased renal blood flow, all come together to cause acute kidney injury. Now, the American College of Cardiology has recently released a risk score to say, but basically indicating factors that put patients at risk. Notice that chronic kidney disease really is a pretty, severe factor showing up here in the list of factors, but it also includes heart failure, anemia, diabetes, patients who are sick upon presentation to the cath lab with shock or heart failure. But in general, you can take these relative risks, these multiples, and multiply it times a population risk of 15% and get an actual risk that's pretty accurate. So the bottom line is severe chronic kidney disease, 3 times 15, and you can anticipate about a 45% chance of a meaningful rise and sustained rise in serum creatinine B when in cases like this. And in fact, there will be a real risk of needing dialysis, much smaller in terms of incidence, but it's real. Now, there's been an evolution of contrast media over time, going from what we used to use in the cath lab in the 1980s and 90s, high osmolar contrast, which was 5 to 8 times the osmolality of blood, down to isoosmolar contrast, which was released in the 1990s. And since that time, there's been no progress in developing a safer, less toxic dye. It's been so frustrating. About 10 years ago, a major manufacturer attempted a series of clinical trials to innovate and have a safer, a better tolerated dye, and it failed. So we've really been stuck, and the number of contrast administrations in the United States has continued to go up and up and up because of the use of CT scanning. So every cancer patient now is getting CT scans every 3 months. The use of invasive radiology procedures. It turns out heart caths and PCIs are actually down a little bit. So it's not really cardiologists driving so much, but it's radiology applications. We have, somewhere around 320 million adults, 320 total population in the United States, 320 million, maybe 240 million adults in the United States. The number of contrast administrations in the United States is estimated at about 30 million. Now, it's not 30 million individuals, it's a much smaller number of individuals who are sick. Like my patient.
Per year.
Yeah, per year. But it's not 30 million people getting contrast, it's a much smaller number, but it's older, sicker people who are getting multiple studies. Okay, like my patient, who in the last year has had, she also has sarcoidosis, so she's already had CT scanning for that. But we haven't gotten to a safer, non-toxic contrast. I do think that's the answer, because it seems like we are not moving to other forms of imaging. We thought MRI was going to completely solve the issue for cardiology. It hasn't panned out as an example. We thought that ultrasound, power Doppler, other things could deliver. We use a lot of ultrasonic technology, but it's still not good enough. And then in cancer, while there is widespread use of PET scanning, the problem with PET scanning is you need the CT with contrast to localize where the hotspot is. So it's actually CT PET. So I've got several relatives in my family with metastatic cancer, and they're all on this, every 3-month CT PET approach, and they're getting contrast CT plus PET scanning every 3 months. Like now with the cancer therapies, people are living a very long time, and so the number of administrations and exposures is skyrocketing. Okay. Here's an important figure from the American College of Cardiology work and from University of Michigan, who have the data, showing that if we actually divide the contrast volume administered divided by the creatinine clearance, one can actually get a number and show that once we get to multiples here, we get this skyrocketing incidence of contrast-induced acute kidney injury that is shown here in terms of this rise in serum creatinine, and even a little different axis here with even a detection for increased incidence of dialysis can approach 1 to 1.2%. So it's not a trivial thing. So you can think about it, if someone has a creatinine clearance of 30, and we go 5 times that in terms of the volume of dye, so 150 cc's of contrast, we would be in this category right here. Okay? So for CT scanning, most of our CT scanning, we can keep the contrast down to about 80 cc's. For heart catheterizations, diagnostically, we can probably keep it down to maybe 60 cc's. But on average, once we get into anything where there is a multiphasic study in the radiology world, or if we want to do an intervention in cardiology, on average, we're in excess of 100 cc's, sometimes closer to 200 cc's. So we can easily get to these high volume of contrast for our ability to filter relationship. The guidelines do support efforts to minimize contrast. So you're going to see this now in the cardiology cath lab, for instance. We do skip parts of the examination, like the left ventriculogram or an aortogram, in order to conserve on contrast. Sometimes we just go with the coronaries, and the internist will ask us, well, did you look at the left ventricle? We'll say, no, we skipped it. We're going to have to look at it by echo because we don't want to, give contrast that can be avoided. A left ventriculogram is actually 10 cc's given for 3 seconds through a power injector. So that's 30 cc's of contrast that we can avoid. And so the guidelines are heavily pushing for us to minimize contrast exposure. We are working on techniques that will allow us to do CAT scanning, for example, with no use of contrast. There was a recent paper, cardiology, of patients at very high risk where they did an angioplasty and stenting with no contrast. Okay. How did they do it? There's only about 10 cases that just was published, where they had a diagnostic coronary angiogram a few weeks ago. They let the patient recover, and they used that as a roadmap. And then they brought the patient back to the catheterization laboratory, and then put up the images here, carefully got the same views, and then actually put the guiding catheter in and got the wires down by looking at the roadmap over here. It can be done. We can use some pressure techniques or intravascular ultrasound. But put it this way, our efforts to get away from contrast are still a long ways away. We're working on it, but it's still a long ways away. Okay, here's the data on this relationship of contrast volume to the estimated GFR or serum creatinine. It's pretty solid. We start to get to more than 3 times or more. This is the threshold we're going to get damage. So if you have somebody with a GFR, it explains a lot. So if you have somebody with a GFR of 60, we'd have to give them 180 cc's of contrast before we prosecute. So you see some of the GFR of 60 or 70, they almost never get contrast. They have enough renal function to get rid of contrast. We get GFRs down below 60, then it's possible to get enough contrast and reduce the ability to get rid of it. That's where we start to get injury. Now, how does this happen? Well, the contrast does hit the kidneys, and in this zone, it doesn't cause any glomerular injury. The contrast is very water-soluble, gets into Bowman space, and then into the renal tubules, And it does precipitate immediate chemical injury to the renal tubules. It actually is very water soluble. It's right into the tubular cells. There's release of cellular material, free radicals. Some of the cells slush off in the tubule, cause a TAM-Korshal protein. And so it directly injures both the proximal and the distal convoluted tubules. Here's electron microscopy. Here's a normal tubular structure. And notice that these tubular cells have a brush border, healthy mitochondria, linking proteins here. Here's the peritubular space, and right next to it is the peritubular capillary network. And in theory, when we give contrast, we actually look at the brush border gets destroyed relatively easily, the contrast gets into cells, and importantly, it gets into the peritubular space. That's where it starts to cause vasoconstriction in the kidneys, and then the contrast gets stuck, literally gets stuck in the kidneys around the tubules and causes more damage. So it's well known in the cath lab, if we actually just take the image intensifier and we bring it down over the kidneys, and the kidneys light up with contrast, we go, oh boy, we got a problem, because we know the contrast is stuck. It ought to be going rapidly through the kidneys. We can see it in the bladder, that's fine, we can void that out, but we don't want it to get stuck in the kidneys. Here's an example of the CT scan, 73-year-old patient with multiple myeloma, graphing's 2.3, getting the CT scan. Here's the bolus. You can see the contrast the bolus is in the aorta. You can see the contrast starting to light up the kidneys here. But 3 days later, 8 days later, there's still contrast in the kidneys. It's not completely out until 17 days later. Now, radiologists and cardiologists, we don't have people come back 2 days later and just take an image and see if the contrast is there. But there have been 4 studies that have looked at this. And I'll tell you, it's the retention of contrast. When your patients go to the hospital for a CT scan, you never think about, you see them back in the office a week later, that there's still some contrast stuck in the kidneys. Well, this only happens in patients who have really decreased renal function to start with. Again, normal renal function, you get rid of the contrast literally within a matter of minutes. But in patients with decreased kidney function, that's where we have retention. Now, the good news is the tubules have regenerative cells in both the proximal and distal tubules, and they can actually regenerate. After injury, there is a cycle of injury, as shown here, down to where there's sloughing and really decreases in renal filtration. And then there is a recovery, and we can regrow this brush border. So there is great hope that, in fact, these episodes of acute kidney injury, there's to some degree, there is some recoverability. But when the injury is sufficiently severe and these tubules become fractured and completely inflamed, it's not recoverable. We have about 1.2 million nephrons that we're born with. We lose nephrons with age. We typically lose about half of them with normal aging. We can do great with half our massive nephrons well into our 80s and 90s. It's just that when we take these hits to the kidneys like this, we lose nephron mass. The remaining nephrons continue to filter okay. That's the reason why we don't see bumps in creatinine. But then we live at a level where we're much more susceptible to the next thing that comes along. In the published studies, there's no doubt about it. These are all patients with severe myocardial infarction, substantial myocardial infarction. So if we have good kidney function at baseline, we have nearly perfect survival after acute MI. All these patients went to the cath lab, reduced renal function, we have markedly reduced survival. So the renal function at baseline is a proxy for how the patient will do over time. Importantly, if patients have contrast acute kidney injury compared to those who don't, the mortality is strikingly higher. It's amazing how high the mortality is. And people have wondered, is this just due to the kidney injury, or is just the manifestation of kidney injury just a proxy for patients who are more severely ill? And the answer is probably a combination of both. But we love it in cardiology when we have no contrast-induced acute kidney injury. We have stunning outcomes. And these are patients with large myocardial infarctions in a prospective randomized trial where PCI was performed. So what's the approach to prevention? My personal view is we need better contrast agents. We really need to stimulate innovation and research to get to a safe contrast. We cannot, in my view, continue to go in medicine where there's increasing amounts of contrast administration through radiology, and all these other different areas and still be using contrast formulations that are 25 years old. I think in today's world of innovation, we should be able to create radio-opaque forms of intravascular contrast that are safe to the human body, and we're just not there yet. We're not seeing actually the clinical trials or innovation. And what's been tried? Well, if we start at the level of the glomerulus, improving renal blood flow. And the ways to do that are largely by expansion of intravascular volume, and that's by use of IV fluids. Dr. Tumlin, who just joined us, as well as others, have led a lot of work with trying to improve renal blood flow by manipulating dopamine receptors as an example, and unfortunately that's failed. If we work down this part of the proximal tubule in the loop of Henle, we can try to attenuate inflammation or oxidation, and there's been attempts to try to change acid-base balance and actually alkalize the environment, which works to reduce some of the speed of the redox equations and oxidative stress and damage. We can try to reduce this tubular and peritubular contrast media stasis by kind of forcing the flow of urine through the tubules and loop of Henle. An antioxidant protective approach could be N-acetylcysteine or vitamin C ascorbic acid, and I'll show you the data on N-acetylcysteine that I think is fairly definitive. I'm not going to touch on ascorbic acid because I think the prevailing view is that it's just simply not effective. We can try to reduce this extravasation of contrast into the peritubular space, and again, the only way we can work on this right now is by trying to force fluid through these conduits, although I was involved in a blocker of the absorption of contrast called cyclodextran, and unfortunately we could not get a sufficient commercial interest in creating an admixture of cyclodextran with contrast. Cyclodextran is believe it or not, it's a solubilizer. It's used with Geodon or Conazole and certain drugs, but it looks like, believe it or not, the contrast gets into these spheres, and it tends to stay in it tends to be extremely water soluble and really tends to stay in the vascular space. It doesn't go past these phospholipid bilayers. But that's the opportunity there. And then lastly, we're down to trying to anticipate volume overload. There's been attempts to try to do early dialysis or preemptive hemofiltration. All of these things are very, very labor intense and unfortunately at a reduced yield. But let's kind of go through the data. Despite all of this, we've published on this that there is a reduction in the rates of serious acute renal failure that's been documented in hospitals over time. So maybe paying attention to this problem, or smaller catheters, use of less toxic dye. One of the things that's come out recently is cardiologists using the radial artery approach as opposed to the femoral approach. So some places in the world are 80 to 90% radial artery approach, where the published randomized trials suggest lower rates of acute kidney injury. At Baylor, we're only about 15% radial artery approach. The risk, in this study, we showed increasing uses of N-acetylcysteine sodium bicarbonate. Although it's just an observation, I'm not sure either one of those really made a difference. But multiple studies have shown rates of acute kidney injury down, which is terrific. Okay. How about the selection of contrast? We've published on this, lots of randomized trials, certainly lots of debate. As a general rule, if we look at intra-arterial administration of contrast, it favors isoosmolar contrast with a pooled estimate here. There is probably about a 50-60% risk relationship. When we have predefined kind of serious levels of acute kidney injury, it looks like it matters. The only isoosmolar contrast available to us in the United States is iodixonol or Visico. Okay, so that's the reason why you see the radiologists specify in high-risk patients isoosmolar contrast. Again, iodixonol is great. It also has the lowest risk of these anaphylactoid reactions. If patients have a contrast allergy, this contrast is more expensive. Otherwise, the lesser expensive low osmolar contrast agents would be used, but in these intra-arterial trials, people at risk, it looks like they've been managed. How about giving IV fluid? So I'm on the CCU service right now at Baylor. We had another patient develop contrast acute kidney injury after the EP doctors put in a biventricular pacer, because even though we put in a pacemaker, when it's biventricular, we actually have to image the coronary venous system to get the lead in. So the patient developed contrast of his kidney injury. So it was on like day or 2 or 3, we saw the creatinine rise, and the intern says, well, we're giving IV fluid. And I made the comment that, it would have been great if we would have given IV fluid before we gave him a contrast. Now, afterwards, the damage is kind of done. Now we're just kind of waterlogging this poor guy. But let's go through the data. And here's one of the trials called the PREVENT trial. This one did examine, it was the biggest one to examine bicarbonate versus saline. So everybody here is getting volume expansion with an isotonic saline solution or an isotonic bicarbonate solution. How you make an isotonic bicarbonate solution is 1 liter of D5W and then 3 ampules of 50 milliequivalents of sodium bicarbonate each. That's how you would make it. And in this trial, there was no difference between either type of contrast fluid. I think this trial was the best to kind of erase this false belief that a bicarbonate solution would make a difference. At one point in time, people were actually giving ampules of sodium bicarbonate in cath lab. Things got pretty crazy. But anyhow, I thought this was pretty convincing. Okay. Now, what has worked out is volume expansion where people really need it. So this recent trial called the Poseidon trial, led by Sam Brar at Kaiser Permanente, took patients cath lab and did something pretty smart, where just putting in a pigtail catheter, you can even just use a right coronary catheter, and just measuring left ventricular end diastolic pressure before you start the case, and then randomize patients to, according to the left ventricular end diastolic pressure, giving fluid, okay, right there in the cath lab, versus kind of a standard hydration approach, and they measured serum creatinine. Now, how this worked was everybody gets a 3 ml per kilogram bolus in the cath lab holding area. So at Baylor, the average patient weighs, I think, 82 kilograms or something like that. So that works out to about a 250 cc bolus. So if you just thought cath lab patient, okay, everybody going to cath lab, 250 cc bolus before the procedure. Pretty easy to remember. We did a study years ago where we actually put in Swan-Ganz catheters in everybody who was held NPO after midnight coming to the cath lab. And it turned out, we found out that a third of patients have wedge pressures less than 8 being held NPO overnight because they're on all these other medications, diuretics, etc. So believe it or not, patients come in volume contracted when we hold them NPO. So the idea here, and he worked with our data to come up with this idea of just give everybody 250 of saline. And then during the procedure, they were randomized to, again, checking the LVP, EDP, and giving some more fluid versus just kind of a standard approach. And how this worked was, if the LV-EDP was less than 13, they get 5 mLs per kilogram per hour. 5 mLs. Okay, so we're talking about, 300 cc's an hour during the case. You're given a decent amount. If it's 13 to 18, now you're back to that 250 mLs an hour, right? And then if the LV-EDP was over 18, now you're down to about half of that, about 125 cc's an hour. This meant everybody in this arm in the cath lab, that means the nurses having IV fluid going in the cath lab, not just kind of trickling in. So it's a different set of cath lab behavior. And you would probably agree it's kind of aggressive on the fluid side. People are kind of worried about putting people in pulmonary edema. The standard hydration was to give everybody going in here this 125 cc's an hour. So these patients were pretty well volume expanded here. Notice I'm not using the word hydration, even though it's on the slide, hydration. My boss at Baylor is Mike Emmett. He's a nephrologist. He is taking that word, he's burned it out of my mouth. Hydration, the word technically refers to water. So if you're talking about changing water in the body, you talk about hydration. Otherwise, We're talking about giving isotonic solutions, we use the word volume expansion. So I've completely changed everything that I've written on this. And so this was done in this Poseidon trial. The maximum rate that they capped off for fluid is 500 mLs an hour. Okay? Here are the data. Baseline creatinine 1.4, estimated GFRs 48, LVEDPs on average were 12, fits with my observation, means about a third, we're certainly below 8. Contrast volumes, 108 cc's of contrast. And then here are the results. Here's the rates of these significant rises in serum creatinine. Definitely, this fell into what we expect. The kind of uniform average for this population is about 15, and so it cut it in half, and that was highly statistically significant. So I give this group a lot of credit. I think they've brought a very evidence-based approach to giving volume expansion in the cath lab. I just wrote kind of the piece that people always rely on, the JECC, on contrast administration. I have this built in. I met with Sam Brar and I've gone over everything. I think this is really a solid approach. Because we're going to give contrast, we got to start revving up flow and expanding volume before the contrast hit the kidney, not afterwards. Okay? There are ways to really supercharge this. Okay? We can actually give a ton of fluid in IV and actually give some Lasix before we give contrast, and then as the urine comes out, we can have a calculator match the urine output and give more fluid in and actually cause a lock. It's called forced hydration. This is through a device called the renal guard, and here are the data from Italy showing here they're using 300 mLs an hour. Remember in Poseidon, they even went up to 500, so we're getting to be pretty similar. The difference is they're replacing the urinary losses and actually getting urine flow well above 300 cc's an hour during these procedures. And this group is working with patients with much lower GFRs. People were terrified. The company went overseas to do the research. They were terrified of putting people in with pulmonary edema, giving this much fluid. But these urine flow rates during the procedure can be as high as 400, 600, 800 mLs an hour. So it's giving a huge amount of fluid. So we have to check electrolytes actually towards the end of the case. Here's the renal guard device here, which is like a fancy IV pump, but it does measure the urine output in the collection bag. We have to put Foley's in to do this. Okay? This is still research. This is not clinical care. It's research. But look at the maximum urine flow rates that we can get in patients. These are patients with reduced GFRs. We can give them a little bit of Lasix and start the infusions. We can get flow rates, again, well in excess of 300 mLs an hour. And there is a very minimal relationship between the change in the serum creatinine. We don't get huge changes in serum creatinine once we get urine flow rates this high. In general, all the studies have shown that in this forced hydration group, we get much lower rates of kidney injury. So this is kind of an exaggerated way to do it. I think the Farrar way to do it is very practical. Both of these sets of investigations suggest volume expansion. Out of all the forms of acute kidney injury that I'm aware of, contrast is the most responsive to volume expansion compared to anything I'm aware of. As long as it's done before and during administration, not 2 days after, like our patient went rounds at Baylor. Okay, N-acetylcysteine, mucomyst, there was great enthusiasm for this. It still is under investigation in the largest trial of contrast right now being done by the VA. 9,000 patients is yet being tested again. I'm part of that committee, and I at least Steve Weisberg. I at least convinced the committee to do something a little bit different. Almost all the studies are given like 2 doses before contrast and 2 doses after, and we know that contrast stays in the kidneys for days. So if there's still equipoise on this issue, my view is at least give the N-acetylcysteine for some reasonable duration of therapy. Not too many things in cardiology and nephrology are 1 or 2 day pathogenesis. It just doesn't work that way. We have to give drugs longer. But in this trial, the ACT trial done in Brazil, which is the most definitive trial done so far, 2,308 patients were randomized, high-quality randomized trial. 28% of patients got PCI, the rest got angiography alone. They did receive fluids before the procedure. 22% had high osmolar contrast, which would be unusual in the United States. The rest had low osmolar. 100 cc contrast load on average. 1,200 milligrams twice a day for 2 doses, before and 2 doses after. So they gave about twice as much as what a lot of other studies done. A pretty good exposure to N-acetylcysteine. And what you can see here in terms of the outcome of acute kidney injury is exactly 12.7% in each group. Completely flat. High quality, prospective, blinded way bigger than the other ones. I think, despite there have been meta-analyses showing this work, this is an example where a large, high-quality trial even overturns a favorable meta-analysis of tiny studies. So at Baylor and other places now across the country, I imagine we don't do this. Okay. Well, to finish and conclude, where are we here? Well, in my view, all patients going to the cath lab should have a creatinine done, or even in the radiology suite across the United States, at Baylor, for instance, they get a point-of-care creatinine even before a contrast CT scan as an outpatient. That didn't happen a few years ago. In fact, Jim and I were involved in a work group a few years ago where people were saying, listen, we're not doing that. In Europe, they were telling us, we're not measuring creatinine prior to contrast exposure, which they weren't doing. And that's changed. Everyone is measuring creatinine now. We get this GFR. When the GFR is over 60, the body is going to be able to get rid of this contrast. Okay? So just good clinical practice is needed. We do discontinue metformin, not because it participates in acute kidney injury. It's just on the off chance that if they do go into an acute kidney injury syndrome, that we're not stuck with the buildup of the metabolites that can cause lactic acidosis. So we had a fatal case actually at Baylor in the last year of metformin lactic acidosis. Mike Emmett, our chair, made a big deal about it. And so it still can happen. And remember, the GFR over 60 is not super golden. If a patient comes in cardiogenic shock, if they have a big wave of atheroembolism, whatever, you still can get acute kidney injury with GFRs over 60, but it's vanishingly rare. The 30 to 59, that's where the risk starts. And so here we want to make sure patients are on statins. I didn't go over the data, but statins in general are protective in all the randomized trials. We want to discontinue non-steroidals and other nephrotoxic drugs. And again, I didn't go over the data, but the other thing I've updated here for the guidelines is that we now are discontinuing ACEs and ARBs. ACEs and ARBs, even though they're protective for the kidneys for long-term diabetic nephropathy, and they're protective and good for heart failure, we're discontinuing them prior to contrast based on recent studies, including a prospective randomized withdrawal trial called the CAPTIVE trial, that I think was pretty solid. So we battled on this for a long time, and our nephrologist, when I was up in Detroit years ago, used to say, hey, listen, we're backing off on the ACEs and ARBs. And they were right. The way you can think about it is, you got to let the kidneys breathe a little bit from a neurohormonal regulatory perspective. So we're stopping the ACEs and ARBs as well. We're administering an isotonic fluid, and a normal saline is fine. In my view, Ringer's lactate would be fine. Baylor, a critical care doctor uses a lot of plasma light, that would be fine. Or a sodium bicarbonate solution if you wanted to do that, provided it's isotonic. I don't think there's much a difference. And we are now starting to follow this Poseidon protocol. Isoosmolar contrast is used if there's additional risk factors like diabetes or acute coronary syndrome. Otherwise, low osmolar contrast, we save money and use low osmolar contrast, is fine. We limit the contrast volume. We've shown we can get down to about 30 cc's for a diagnostic. We may not be able to do all 4 quadrants, which we typically do with the image intensifier in the cath lab. We may just get a single shot of the left and a single shot of the right, but in the setting of normal coronaries, maybe that's all we need to do. We can get down to less than 100 cc's for a diagnostic intervention. That always means skipping the left ventriculogram and being very judicious in our use of contrast. There are some contrast-saving devices. There's something called, I think it's called the divert system. They help the doctor prevent from over-injecting through the manifold. And these devices do cut the contrast use by about 50%. And so one of our 2 heart hospitals is involved in research there, and these look quite promising. So we may have just a little different manifold set up in the cath lab, and radiologists, when they do pulmonary angiograms, and others can use it as well, to actually prevent this overshooting. But when we inject contrast, we're using our hand in our field, and we tend to kind of overdo it. And there is a pressure system that can prevent the overshooting there. So that's really exciting. GFRs below 30, we do all the stuff here, but then GFRs below 30, we actually start to work with our nephrologists. We always use isosmolar contrast. We're trying all different types of strategies here. Here's a risk population that's so sufficiently high. We are starting to measure this new test for acute kidney injury called the Nephrocheck test. I just started at Baylor in the last month, and it's just in our high-risk patients. They're going to stay in the hospital. The Nephrocheck test measures the mathematical multiplication of the insulin-like growth factor binding protein 7 and tissue inhibitor metalloproteinase 2. It's not shown on this slide, but the Nephrocheck test is useful. There's one called NGAL, which is used in Europe and Australia and South America, and then fatty acid binding protein, which is used in Japan. So there are some of these novel markers that in general can tell us, they can forecast for us that the creatinine is going to rise about a day or two before the creatinine takes off. So in high-risk patients where we're expecting acute kidney injury, the value of these tests are when they're negative, because the negative predictive value is so strong. So if we do a high-risk, we have somebody creatinine of 2, and we've done a high-risk PCI, the real question we have is, oh boy, are they going to get sick in 2 days with acute renal failure? Well, the value of these new tests is that the negative predictive value says, no, they're not. So in fact, we can let them go home. We don't have to kind of sit and wait. So people have kind of misinterpreted, I think, how to use these tests. They think the positive predictive value is going to help. We're kind of doing a lot of what we're going to do anyway, like watching and waiting and worrying, but it's the negative predictive value which I think changes clinical decision making. So to finish and conclude, I think the pivotal question here, and we'll have tons of time for questions, the pivotal question that Jim and I and others have been working on, it just seems like decades now, which it is decades, is, if we can prevent acute kidney injury, in this case contrast, but we could say sepsis or other causes of acute kidney injury, we can prevent acute kidney injury. Can we really influence these rates of other events, death, the use of dialysis, rehospitalization, heart failure, acute coronary syndromes, arrhythmias, and stroke? How strong is this cardiorenal connection? There is a belief out there that the kidneys and the heart are talking all the time. When the kidneys get whacked, there's a set of signals that get sent to the heart and the vasculature, and that's part of this, why we see like these giant differences in mortality. So why would mortality be 2% when there's no acute kidney injury, when there's 25% with injury? Now some of that may just be confounding, but if any one of that differential is biologic, our hope is with a strategy that reduces acute kidney injury, that we would have this benefit that spreads over to the cardiovascular system. That is the fundamental hypothesis being tested in all of these cardiorenal trials right now. I think before the end of my career, I would just want to know if this is right. If these things are completely independent, that's useful to know too. Right now we don't know. We've seen an incredible signal in all the clinical trials and observational data that in fact the heart and the kidneys are working together in an axis. And so far our chronic therapies that really work in cardiovascular medicine and nephrology, they work on cardiorenal systems like ACE inhibitors and ARBs. Beta blockers work on the cardiorenal system. So I still hold out a lot of hope that we'll prove our hypothesis. But if we do, and we change long-term prognosis, by what mechanisms? So that's the reason why we're working with so many novel compounds. And we have to go through a lot of novel compounds until we come up with success. I just finished a major randomized trial, multi-center, and published it in the online version of Circulation, where we tested a novel agent to try to prevent all this. And it was an agonist for a particular hormonal receptor, or an alpha melanocytes hormonal receptor, which are pretty dense in the renal mesangial cells, and this form of therapy had no influence. Just finished another whole experiment with a cellular signaling mechanism inside it's called the SNAP pathway, inside the renal tubular cells. Again, giving powerful drugs, no influence. So we're going to have to go through a lot of these before we hit what we think is a protective compound in kidneys. So I'll stop here and open up for questions and comments. Thanks for making it here for lunch. Questions? Yeah.
We talked about stopping the various medications.
Yeah.
I presume this is on an inpatient basis, so that you're able to monitor them and intervene with other agents, and then continue your other interventions, primary contrast.
Yeah, right now it looks like, for the ACEs and ARBs, we can just stop them, the day before or day of the procedure. So they rush out of the system.
Okay, so post-procedural, then it's not so much concern, but pre, just get them all.
No, in the randomized trial, they stop them post-procedure for 5 days. But it looks like, honestly, you can stop an ACE or an ARB briefly, and I don't think there's any kind of
I think it's a very interesting approach. Is there any consensus, like, in terms of both informing and cases? I see, like, potentially different stuff, like, some of them would, like, stop it before they and even 48 hours or after 48 hours. What would be the good taking point, like, when to stop and when to start back?
I think if we were to be really tight on it, I'm trying to think what we could in the recent cases you just put out. I think I'd stop it, put some document, 24 to 48 hours before procedure stop cases, and then we start. There hasn't been any, some people say, well, you have to check if you have to have before you start that point. I mean, honestly, unless there's been some clinical change in the patient, I wouldn't agree with that. Well, hopefully use newer urine